evening to everyone. We, the Association for Veterinary Dermatology India, and our knowledge partner, Alembic Pharmaceuticals India Private Limited, we are very much happy to welcome you all in this evening for a great dermatology lecture webinar. So this is after a long time we are meeting, and now we started doing our activities with full swing. So as you all know, we are going to have our next Congress in Pune, that is on 13th to 15th June 2025 at Hyatt Regency Hotel. We are planning to have one pre-Congress workshop also, and I expect all of you to come over there and grace the occasion. And it will be a great event because we are going to bring 3 international speakers who are the top end, that is, they are the global leaders for the veterinary dermatology. One from UK, another from Japan, another from Germany will come, and they are going to give a great lectures. So don't miss it. I welcome all of you for that great event. So reserve your date for that. And there is no need to introduce our Dr. Neelam Singh, known to everyone all over India. I will introduce her before today. She is the guest speaker for us. So it is with a great pleasure I am introducing my own student, outstanding student, Dr. Neelam Singh Josan, who is known to me since her undergraduate days in Madras Veterinary College, where I was her teacher in the Department of Madras Veterinary Medicine and Medicine Department at Madras Veterinary College, Chennai. She has made a significant contribution in veterinary dermatological activities in India. Over the last 3 years, our association has held congresses, dermatology workshops, and all the activities, even the dermatology camps. So where she has demonstrated her exceptional organization skill. She has received a WAVD, that is World Association for Veterinary Dermatology scholarship to attend the World Congress in Boston. She attended that. We all went there. We had a very nice time. In future, we will go with a great attendance. And it was very knowledge gaining experience. It was very wonderful exposure to our veterinarian, Indian veterinarian to other country veterinarian. So it was a very great event. So we can, in future, we'll go in more number so that everyone will be seeing India as a growing dermatology area in India. She was awarded with the NVF Ratna Professional Excellence Award for her contribution in spreading her constant learning experiences with the veterinarians in India. So that also she received. So with all these things, she had got a very good approach to veterinarian as well as colleague veterinarian. And also the subjects, you might have seen in all the WhatsApp group, her immediate reaction for any, not only in dermatology, even in other subjects, she is going to have interest. But particularly, she is very much interested in dermatology, and she is doing good work, and she is great. She is uplifting her knowledge by attending all these activities. So I wish her all success in future, and she'll be giving wonderful lectures in future also. So I welcome her for her first webinar lecture for this evening. Thank you. I welcome Dr. Neelam Singh to start the webinar.
Thank you so much, sir, for that introduction.
Okay.
Good evening, everyone. I'm really thankful to AVD, Dr. Nagarajan, sir, and our knowledge partner, Alembic, Dr. Shinde, sir, for giving me this opportunity to present this lecture on the systematic approach for dermatological cases in our general pet practices. So it's a Sunday evening, I understand that, so I'm going to keep it very short, crisp. So this presentation is kind of an SOP, step-by-step approach, or you can say a protocol that you need to follow to handle our derma cases efficiently. So these derma cases, we all would have experienced, they constitute almost more than 50% of our cases in general pet practices. Cutaneous lesions, as you would have always seen, they are always not pathognomonic. So every case is like a storybook, which you need to read through, and you cannot go to the summary directly. So you have to go step by step. Understanding the whole script is the key to understanding, the skin issue. Derma cases, they are a major challenge. And we all would have felt maybe, even a main cause of loss of clients to another practice because of dissatisfaction, because maybe we are not able to handle those cases efficiently. Like William Osler very rightly said, the great physician also understands the patient and the context of that patient's illness. So we know that skin is the largest organ, and it can always show signs with primary skin condition, or it can even have causes due to involvement of other organs, which can be the main cause, like, a dog having arthritis, he can exhibit acral leg dermatitis. Cushing dogs can show, lesion on the skin, which can be thinning of the skin. You can have calcium deposits on the skin. A hypothyroidic dog can have recurrent pyodermas. So always look out for the cause. So for that, you will need to identify the problem, which you'll have to go step by step, which we'll discuss today. Then you make a list of your differentials. Then you do the correct test to confirm your diagnosis, and you come to the appropriate treatment that you give accordingly. So you have to actually play a detective in dermatology. Vet has to be like a detective to to solve this pet's skin mystery. And you have to try to get as much info as possible about the patient. So you need to talk a lot, observe a lot. You have to, for solving the pet puzzle, you have to, understand the pet and the owner all. You have to have excellent communication skills. You have to gather the history in appropriate depth. You have to do a physical examination, which is very thorough. You have to do the diagnostic test. Then you collect the appropriate data, construct the patient story, making the correct diagnosis. Then you have to plan and set the treatment goals. And then you have to keep in mind the personal situation of the pet parent, which is really essential. We cannot make a plan which is not followed by the owner. So you have to focus on the signalment and the other parameters that I've listed here. So coming to a correct diagnosis, it's like a pyramid. So if you have a pyramid, so your diagnosis is here at the tip and the history is here at the base. So the history is really important. For me, if you say, if I'm given a choice between diagnostic test and a history, I would always choose history. So in solving the pet puzzle, you have to go through all these parameters, which we'll see one by one. So these are all my poster boys in my derma clinic. You have these breeds in your clinic, you have your derma clinic running. So here, when we see a breed predilection, you see certain breeds and your differentials in that list, suddenly one differential will top up. It will come on the top of the list. So if you have say, bulldog, your Shih Tzus, beagles, your retrievers, wherever your atopy is, it comes up. Then you have your huskies, you know what it is. Your Persians, you have dermatophytosis, ear mites. Your Pomeranians, alopecia X. You have your Cocker Spaniels, then your Rottweilers, then your poodles. So color, in that also, you have diluted color. So you'll have color dilution alopecia, then you suspect that. You have white dogs, then you can suspect, when you have certain skin lesions, you can, suspect this squamous cell carcinoma. I'm sorry. Then you come to the onset of age of onset. So here, when you have, a very small puppy, a very young puppy, you suddenly have parasites coming into your mind, juvenile cellulitis, A less than 4-month-old puppy, you'll see congenital disorders also popping up. You'll see signs related to that, wherein your demodicosis, pituitary dwarfism, ichthyosis, dermatophytosis, dermatomyositis, all these will come up in that age category. You suspect them more. When you have a puppy from 4 to 12 months of age, so then you come to canine acne, color dilution alopecia, histiocytomas, your zinc responsive dermatosis, your viral papilloma. So suddenly, you have these differentials more during that phase. Then you have your young adults, which is between around 1 to 3 years of age. So in that age group, your atopies, your cutaneous adverse food reactions will come up. You have your middle-aged dogs where you would suspect endocrine pathologies more, like your hypothyroid Cushing's. And old age, of course, neoplasia always, comes up on your differentials. So now next would be our location of lesions. Certain areas when you have a prominence, your differentials will be different again. Like you have lesions on the rump, ventral abdomen, tail. The dog is very itchy. Your flea bite dermatitis will be there. Then you have scabies wherein your ear margins, your elbow crusting, your hock crusting. Whereas in allergies, you'll have the concave surface of the pinna, your ventral abdomen, interdigital spaces, your periocular, perioral areas, erythema will be there. So you have your differentials depending on the lesions also. Suddenly, you'll have a list again according to that. Now with the type of lesions, you have primary lesions, which could be pathological changes you see on the skin, which are a direct result of the underlying disease, like you have papules, pustules, macules, which you can see in Demodex. Then you have secondary lesions, which are changes due to progression of the primary lesion or due to the consequence of your, self-induced damage, like your crust, your collarettes, your calluses, your alopecias. So when you see the lesions here, you see a hotspot, which can be a flea, which can be any trigger. Then you have skin thinning here, which is you can see in your Cushing's also. Then you have indolent ulcers, fat lips, eosinophilic plaques seen more in your allergic cats, your Demodex puppy, then your pyodermic lesion. Then you have these comedones, which can be your steroidal use, which can be your Demodex also. Now alopecia, this lesion, it can be spontaneous, which can be, your hair cycle arrest, or it can be endocrine related also, or it can be self-induced like in allergies, or you can, differentiate into inflammatory or non-inflammatory alopecia also. So here, like it is, self-induced cat licking the area. Then you have the spontaneous in alopecia X. Then you have this is the special category which everyone would have seen, these huskies which are shaved and then they don't get a proper hair coat. We call it as post-clipping alopecia. Then this is very commonly again seen steroidal application. You have hair loss here. Then you have your pyodermas expanding. This is a case of a sugar diabetic dog where you have this hypotrichosis, hyperpigmentation. This is all related to his endocrine issue. Now, another feature that you have to notice is the pruritus. Again, in pruritus, what you have to see, whether the pruritus comes first or you see a lesion and then you see the itching. For this, you have a very good scale here, visual analog scale. It's a 10 centimeter scale with 0 being a normal dog and 10 being an extremely itchy dog. Here, another important thing with pet parents is, they would most of the time say, my dog is not itchy. So you have to ask them questions like, is your dog rubbing himself against the carpet? Is he licking himself? Is he nibbling? Then when you start saying, they say, yeah, doctor, he's been licking his paws too much. He's been flapping his ears too much. He's been shaking his head. So, these all are signs of itching. Which the pet parents generally don't realize till you ask them these questions. Another way of checking whether the dog is itchy is he's been licking himself is you can check for hair in between the teeth. You can even pull out some hair and you can look it under the microscope. You see the broken tips of the hair, then you understand that the dog has been licking himself. Here, another thing that you can use for differentiating is like if you see a dog with lot of hair loss, but the itching scale is, the number is just 1. So I'm not going to take it as allergy, right? Because allergic dog, if he's having that kind of itch and biting himself so much, so he would be somewhere at least around 5, 6 there. Now with the progression of lesions, that also is very important. You have to see the onset of the lesions, whether it is an acute onset, which we can see in scabies, whether it's progressively worse, which generally you see in allergies, starting with licking, and then you have your secondary bacterial infections and all that. Whether the progression has been in days, weeks, months, or years, and in stray dogs, where of course we really don't know whether it's been always there like that or it's been a short duration thing. Seasonality again is very important. Warm weather, when you see the itching and all those lesions, you generally think of fleas, pollens as the triggers. If you have something going around the year, then you will think of food allergies because you have that food as a trigger throughout. Then you have house dust mites, which can be a trigger. There are these cases which have these initiation throughout the year, but it gets more pronounced in warm weather. So it will be a combination of the top two. So, and sometimes you have stray dogs year round, again, you don't know about it. Then something, lesions throughout the year, more pronounced in the winter, which then you can, maybe put it more to house dust mites because the dog has been staying more indoors. So maybe he is exposed to those more. Along with these skin lesions, you will then see other concurrent non-dermatological signs. So you have sneezing, conjunctivitis, which you can see in your atopies also. You have GI symptoms, which can be a food allergy thing. You have PUPD, polyphagia, dullness. All these can be along with your endocrine diseases. And with neoplasia, you always have that cachexia, which gives you an indication. And along with this, collect the other important history, like, whether there has been a spread between the pets, whether there is a spread from the pet to the human, which will, indicate dermatophytes, scabies, notohydrous in cats. Did the pet travel anywhere? Does the pet stay indoors completely, or he is an indoor-outdoor pet? Any new food that you gave to the pet or any drug was given? Are there any siblings that are affected? So all these will give you certain more relevance to your diagnosis. So now here is another situation now with which you have to handle as the veterinarian. So you have these patients, they want treatment on the phone. So without sounding rude or money-minded, you have to suggest some safe option which may or may not work. And you can always say, okay, if it doesn't work after 5, 6 days, you come over. So you have to be very careful with handling these pet parents because, if you don't give them a solution, they will definitely brand you as money-minded, So just be very careful. And another thing is when they're telling you something, be careful about that relevance. Sometimes like some few days back, I had a patient where the owner said, this growth has come up overnight. And I was like, okay, let's still do a test because the feeling of that growth wasn't going with his, because it wasn't looking like a hematoma. So we did a FNAC scent. It came out to be a cancerous growth. Sometimes owners will feel embarrassed, that we are going to judge them. So you take their history, whatever they're saying, but then you do your workup also. Now, dialogue with the owner, and along with the owner, the person who is going to take care of the pet, his medication, that is really important. Because most of the times, you tell something to the servant, the owner does not know the owner, you say to the owner, the servant does not follow it up. They come up after a month and then they still have some pills left with them and then they have a complaint that it hasn't worked. So basically, you have to, get a lot of information from the owner. You have to prescribe things, understanding their lifestyle. whether their working hours are such, they can follow the topicals. You have to take into consideration the limitations of the owners also, if say it's an old owner, he will not be able to do quite a few things. Then the nature and size of the dog, whether the owner can even handle the medicine that you are suggesting, okay? So here, most of the cases that we are dealing in dermatology or certain other specialties like cardiology, your oncology, you have patients coming in for long with you. So you have to develop a community with them. Dealing with most of these conditions, you have an emotional backup with the owners. So make the parents a part of the team in their pets management. They feel more relevant, when they are told, this all we have to do to make him comfortable. And derm is more like a management and not perfection. So that is important for us, to even make the pet parents understand this. So treatment course in our specialty changes. You have flares, so suddenly your protocols will change. You may need to give additional medicines, but making them a part of community, with that, one important thing is you have to set boundaries with them, because they should not take advantage of that. So sometimes, they'll come and they'll charge at you because you have been too friendly with them. So those boundaries they should know, and you have to just explain the situation to them. So here, these are the pet parents that I just love. They have so much of history, which gives me so much of information. We have a limitation here in India because we don't have that derm intake form, being given, because most of the owners just don't like filling it up. So you have to get that history, spend that a lot of time with them. So if given a choice between history and the diagnostic test, I always choose history. It gives me so much data to make my differentials. So after all this, after your signalment, after all your history taking, now is the time for your general clinical examination. You have to check the lymph nodes, abdominal palpations, which gives you idea about the other things which could be related to your skin. Then you do a complete derm examination. And in cats, one important thing is oral examination is an important feature of your complete derm exam. You have to look into the mouth of the cat. So here again, another thing is, like I said before, don't completely trust the owner. That tumor story that I told you, just be careful about it. And one important thing here is in derm cases, documentation, because once the owner comes back after 30 days, he might say, there's not much improvement. But when you show them the picture, okay, this was 30 days back, then he says, yeah, looks better, doc. So as per the data that we have collected, the type of the lesions, the history of occurrence, previous medications, then you decide on the type of the test that you want to do. Just get the appropriate test done. Don't, get in all the tests in the list that you have, because derm treatment as it is, it's little heavy on the pocket of the owners. So where we can save money, but that does not mean save money on the test which will compromise our diagnostics. So just don't do everything, but do the appropriate test. Take the history which helps you in, coming to that conclusion. And don't compromise on medicine and the pharmaceutical quality, right? So you will do your in-house cytology. Cytology is a must. If you are seeing derm cases, you just cannot do away without cytology. Trichograms are again very easy to do, skin scrapings, then you have wood lamps. You just don't have any investment, not major money involved in this. Get the basic test done, the CBCs, liver function, urine analysis and all that. And sometimes you need your ultrasounds to rule out your cryptorchidism, anything related to your Cushing or other endocrine things. So all this history taking, it takes a lot of time. So like I said, that derm intake form is not there. So you set up sufficient time for your appointment, at least the first appointment, because you really don't want to miss out on things. And during the next visit, you don't want to add on something which you missed out on the first one, right? So you just need a lot of time to understand. In derm, you'll have to give time to your patient. So you have done your physical exam, you did your clinical signs, you have your test results. So now you construct your patient story. Make the correct diagnosis. We are not looking at hit and trial here. Now set the treatment goals, which is on your evidence-based treatment. Please, please, please don't follow that I have been doing it through the years and it has been working. It has to be evidence-based now. And keep in mind the personal situation of the pet parent where you have their other features, spending capacity and all that. So you just do all that, whether the owner can give a bath and all, like I discussed earlier. So here is our team where we went to Boston recently and our stalwarts of dermatology in India. So be a part of the community. I would really say that it was such a out of the world feeling that we had at the global level and learning the advancements. Now with all that base that I have given about the systematic approach, we'll just see a few clinical cases, just 2 of those maybe. Max is a 4-year-old male French bulldog. He was presented to me with being in e-collar for 2 years. So since 2 years of age, he was in an e-collar. And these kind of cases really break your heart, Being in an e-collar does not give him any comfort. He has that itching feeling, so we have to give comfort to him. You see the lesions? He has lichenification, hyperpigmentation, erythema. Periocular, perioral lesions, intertrigo, everywhere. He was in such a bad shape. Interdigital erythema, crusting. So with the breed that is presented to you, French Bulldog, suddenly with these lesions, you have a certain diseases which come up in the differentials. Age of onset, 2 years, young adult, location, face, feet, abdomen, axilla, ears, progression is, in this case, is year round. So we'll come to that. Any concurrent non-dermatological signs were redness and watery eyes. Any new food? No. Itching was really bad. And he was given glucocorticoids, which gave relief to him intermittently. So this gives me an indication, of certain disease. So first thing when I do to this kind of case, the first test that comes to my mind and we should all do is a cytology. And seeing this cytology result, we all know what it is. These are the malacesias. Then the blood tests were all within normal limits. Urine analysis was all normal. Scrape was negative, but as we all know, sarcoptes can be false negative also. So that you still keep in the back of your mind. Allergy test I have not done here because we don't have immunotherapy right now. The dog is in such a condition, we have to make him comfortable. There's no point doing it right now. Elimination diet trial in this condition at this point does not make sense because he's already inflamed. So that will be done at a later stage. So now everything points to atopy, where you have to see this favorites criteria, where max is definitely when they come up in 5 or more of these, there are 80% chance that it is atopic dermatitis. He was less than 3 years old. He was majorly indoors. He had a corticosteroid responsive pruritus. He had yeast infection. He had his affected front feet. His pinna were affected. Margins were affected because it was a chronic case. So this is negative here. And non-affected dorsolumbar, this also is negative here because he was on a long standing case. So he was itching there also. So this was there again true, pruritus without skin lesions at the onset. So we have almost 6 or 7 of these are confirming our atopy. So the treatment plan that we made for Max was, we put him on isoxazolines, even though our scrapings were negative, because we don't want them to be, misdiagnosed and we give all the other treatment. And we by chance have sarcoptes also. So we have given isoxazoline here. Then we have given glucocorticoids plus cyclosporin. Your topicals on the ear because it was really bad. Your topical shampoos and sprays, because I have not given oral anti-malassezia treatment. I've not given the azoles to him. I've just given topicals here. And these essential fatty acids for your skin barrier. And probiotics, because atopic dogs are generally found to be having a dysbiosis in their gut also. So I have started him on this also. So max after 3 weeks of treatment, the pruritus has reduced significantly. Malassezia is still seen on cytology. So we have tapered the steroid dose here, and other medicines continued. Now our target is this removal of the E-cone. After 6 weeks of treatment, he didn't have a pruritus, skin was healing. And then after 10 weeks, no pruritus, skin healing. The owner was very happy, but I am still looking in for hair growth around these areas. Everything had healed beautifully, and the dog was really happy. The owner, of course, is happy. Now we have a second case. He is Zar, a 4.5-month-old male German Shepherd. He had progressive alopecia, and the previous vet had advised a steroidal cream which didn't help him. And he was mildly itchy when he was presented to us. So when you see the breed German Shepherds, you have certain immune related things in your mind going on. Age of onset, it's very young, so parasites are definitely there. Genetic development, hypotrichia, I might think seeing this. Then the type of lesion is, we see gray kind of skin here. Lesions are generalized. The progression, it has been progressive. Seasonality, we can't say because he's just 4.5 months old. And any concurrent signs, no. No new food or drug administered except for the steroidal cream that was being given. Nobody in the house was affected. Itching was slightly there. Weak immune system, maybe. German Shepherds, as it is, you know about their immune system. So now we go in for the correct diagnostic test. We do the cytology. Tape impression, we see the cocci here. Then we do the trichogram because this dog has extensive lesions, a gray skin. You have melanin incontinence, which can be seen in Demodex. So we have done more hair plucks because more hair you do, more chances of finding Demodex at the base before doing the deep skin scrapings. And with the trichogram itself, we were able to see so many of these. We didn't go ahead with the deep skin scraping in this case at this point. So you have these other techniques also. Biopsy is a very expensive way to diagnose a Demodex. I would not go in for this. So now the treatment plan for ZAR was, first was isoxazolines again. Then we have these options, but I did that. For mild cases, you can use this combination, but for him, we may or may not be successful. This I'm not using these days. Moreover, if the skin is inflamed, it's not advised also. You have lime sulfur dips, antimicrobial washes, which I have done for him. I've not given any oral antibacterial here. I've just used medicated washes and sprays. Here we have to work on the nutrition, the deworming aspect, and later on this pet has to be neutered. We don't want him to be bred. This is the recovery. So now here we are not sure whether this Demodex flared up because we were using steroidal creams extensively, which suppressed our immune system, or it was just the inherent weak immune system of ZAR, which could have gone there. So these were my two cases. This slide is just to show you a thing like even if you're going systematically, you see the location of lesions almost similar, but these cases are different. This was a hypothyroidic dog, and this is a flea bite dermatitis dog. So they might look very similar. So you cannot, just see the location and come to it. You have to go with the diagnostics to come to a conclusion. So this slide is basically to give the importance of all the steps to be followed in coming to the diagnosis. Now, just a few slides on a topic which I'm really sensitive about. AMR is really close to my heart. India being third in the world after I think China and Kuwait in multi-drug resistant microbes. So new antimicrobials are being discovered by scientists, but you cannot have that kind of research, to give so many products. So we have to make our antibiotics work for longer. Our role as a veterinarian is critical in One Health. These, resistant microbes, due to careless use of broad spectrum antibiotics that we all may be doing, and we are using the same type of drugs and treating the same organisms sometimes as the humans. So our role in preserving those antibiotics is all the more important. Multi-drug resistant microbes, they are being transmitted from animals to humans too. So, we really need to step up on this. I was really surprised the other day, there was a representative who came with the formulation of linezolid, and he was giving me an explanation that, ma'am, you will be able to treat all infections. And I was like, my God, linezolid leaves something for humans also. We don't have to, why do we have to go to linezolid to treat something like a superficial pyoderma? The reasons why we might have more of antimicrobial usage will come up to our vet client interactions. One would be major is antimicrobial resistance knowledge. Maybe we are still not aware how things are going. There are almost, more than 1 million cases of multi-drug resistant deaths worldwide. By 2050, that figure might be many millions. So we really need to, do something about it. Sometimes the clients might demand an antibiotic because it's convenient to them. Sometimes we might think, just in case the topicals don't work, shortage of client consultation time. So because of that, you don't have a proper communication with the pet parent, because of which, you might be coming into systemic antimicrobials if not needed still. Then the pet parent generally has good trust with the veterinarian. So if we are able to convince them, that this issue can be taken care of with maybe topicals. If not, then we'll come to systemic. I think they understand that. They give you time to uh, cover up that issue. And practice culture, sometimes, we older vets might be little hesitant to follow the new pattern. Not all of us, but yes, that can be there. We have been following a trend. So for us to change some pattern might be little, you might need a little more push. So I think we all will get onto it now. Superficial pyoderma cases, this lecture is not about that, but I just thought I'll just add this. Superficial pyoderma cases should get systemic antibiotics only if the case has failed to respond to topicals, or say the pet is aggressive, or the owner can't do topicals like the old age I mentioned earlier, or they don't have a facility to do the topicals, like shampoos you can't do, every fourth, fifth day. Systemic antimicrobial should not be there just for your convenience or the pet parent's convenience. Our topical therapy advantages would be, all these. It reduces the need for systemic antimicrobials. Systemic antimicrobials, when you're playing up with the gut health badly. And because of that, you have severe adverse effects also. Topicals, they are very effective in your superficial and surface pyodermas. They are a good adjunct therapy to reduce the duration of systemic antimicrobials when they're used, say, for deep pyodermas. They are effective against both susceptible and resistant staphylococci, methicillin resistant also. They can reduce the environmental contamination by these strains, and it gives a high local strength. So that is able to even control the resistant strains at times. And they are safe, they are tolerated well, they are effective for long-term duration, and they are cost-effective as well. So topical antiseptics that you can use could be chlorhexidine, your hypochlorous acid, povidone iodine. Topical antibiotics that you can use could be fusidic acid, polymyxin B, neomycin. Mupirocin also is there in the list, but I would avoid that because that is really important again for human usage. Now we come to the 5 Ds of antimicrobial stewardship. first and foremost is confirm the bacterial infection. Don't go by guesswork. Do your cytologies. If needed, first line antibiotics empirically you can use. For first time antibiotic use, you can go with those first line drugs. If recurrence or deep pyoderma is there, then you should culture and use. And there again, the type of drug that you're using, that is important. The duration for which you use, the dosage at which you use. And once you do a culture sensitivity, and in case the antibiotic comes up, a first line that you can use, then you can de-escalate also your antibiotic. You need not continue with your second line in case you get a first line which can be effective. Then don't use antibiotics just to mask your clinical problems. And recurrent infections, they are not antibiotic deficiency. That's a very strong statement that I read somewhere. And really, I agree with that, So you have to find the primary cause why these recurrent infections are happening. So now for the selection of our systemic antibiotics, this is the latest ISCAT guidelines, which will be coming up shortly, which will be published shortly. So here there have been a few changes where doxycycline, which was in the first choice, has come up into the second choice because they are not very sure about the susceptibility of Staphylococcus to doxy. So they have brought it here in case the culture sensitivity says so, this can be used. Then your enro and fluoroquinolones, important here. This trimethoprim sulfa, which was again in the first choice, it has come up into second choice now because of the adverse effects that they can cause. So if need be, we can still use it, but they have been shifted from the first to the second now. These antibiotics are only for methicillin resistant strains that you use in case it's needed. And these are not to be used at all. Completely avoid these. We have seen, these carbapenems being used too much these days. So we really need to be careful. Alembic has very good preparations of amoxiclav, yoseflexin also, doxycycline also. So we can use those drugs when needed if we have to come to systemic antibiotics. Fluoroquinolones, again, we have to be very careful because their residues are very some. We have to be really careful about this usage. Again, the dosage is important. They have come up to enroll 10 milligram per kg minimum dosage. The duration can be 24 hours if needed. We know the doses of amoxiclav and cefalexins we all have been using. Now, again, the duration of usage has been changed. Earlier, for superficial pyoderma, if you had to use these antibiotics, it was mentioned 3 weeks and then 1 week beyond resolution. Now they are trying to reduce it to 2 weeks. Have a check. If needed, you can just continue with topicals. So it is basically you have shortened the duration. So now for the summary of what we have done till now, it is you're following your systematic approach for the correct diagnosis. You must identify the primary and secondary causes of infection. Topical therapy is always preferred. In case of recurrent pyoderma, do culture sensitivity, avoid fluoroquinolones. Right dosage and interval is very important. Appropriate time of treatment is very essential. And your environment disinfection and proper hygiene is required. I would encourage you all to, just take this pledge to be a guardian, to use antibiotics responsibly. And I invite you on behalf of AVD for the 4th edition of ICVD, which will be held at Pune from 13 to 15 June 2025, as was told by Sir also at the beginning of this presentation. Keep your learning curve going higher by attending this Congress and stay in sync with the latest development in the world of veterinary dermatology. Thank you so much.
Hi guys, Dr. Jairam here. Anti-allergics, either topically or systemically. Mr. Dr. Rajesh Kumar is asked.
See, for allergic condition, especially if you are in our part of the country, these days, the atopy cases are on the peak. So anti-allergy orally, yes. Topically, your washings weekly, which remove your triggers from the body, they are important. That you can follow up. But you have to protect the skin barrier. That is again a very important aspect of this. So atopy can be a one separate lecture that we can have to take all the step-by-step thing, because there are so many factors involved in this.
Moreover, it is always multimodal approach.
Sorry, sir?
It is a multimodal approach
Yes,
we have to
yes.
follow in atopy. So
Yes.
everything will be included orally, topically, and the thing.
Yes, sir. Atopy can't be just handled just like that. There's so many factors, and it's a lifelong approach that we have to do. Please inform the dosing. With corticosteroid, we use at anti-inflammatory dose most of the times, which can be 0.5 milligram per kg. And cyclosporin for this pet was used as 5 milligram per kg. And steroids are tapered eventually, because cyclosporin takes around 3 to 4 weeks to build up in the blood to start taking effect. Yeah, contact dermatitis due to Lysol is very common. We can see that. Apoquel, yes, we definitely use. See, erythema in the paws and insistent licking could be a sign of your allergies only. There is a term called atopy march, wherein this year maybe he's having just this sign, next year he might have other things also coming up. So that's too big a topic to be handled right now, maybe. The blood tests for atopy are not there. Actually, the allergy tests are there. They can be useful, in case you say get some parameters out of those which you can avoid. Say you have some pollen, maybe you can avoid if that's in your area. They are mainly useful if we are doing immunotherapies, which we are still, I think only Sir is doing it in India maybe right now. For us who are not doing it, it may not be a great thing. Dog wants to lay under sun for hours. Could be a hypothyroidic pet also, and some breeds just love to bask in the sun. Cytopoint injection, where did I see? Cytopoint injection, it is a good thing. We can use for these atopic pets. But again, the usage has a few conditions when you can use it independently, where you might need a little support with it. Cephalexin can be 22 to 25 milligram per kg, BD. No, I didn't use both doramectin and isoxazoline. It was just meant that we can use one of these. I preferred isoxazoline. That was just, what all we can use in that case.
Okay, thank you. Thank you very much for the wonderful session.
Thank you, sir.
Dr. Neelam Singh. I request Dr. Jairam to give vote of thanks.
Thank you, Dr. Neelam. Excellent presentation, very good for all the general practitioners. You were able to lay in all the points, and I am sure the 250 people who attended would have taken home the message. And AVD is very happy to be partner in this responsible antimicrobial stewardship. I really request everybody to follow the dermatological systematic approach that Dr. Neelam has outlined. It is the core of any successful treatment. AVD would like to thank Alembic and all the entire pharmaceutical industry which has supported us in the endeavor in hosting these webinars. Dr. Nagarajan has been pioneering all the lectures. We would request you to spread the word and join in as many webinars as we are able to put together. The ICVD 4 is happening in Pune. The dates are already put out for you. The world's best are going to be coming in. Do block your dates and do come over. I thank AVD, Alembic for supporting this. Everybody please support Petal. Petal is Pet Alembic Division, and hope to see you all again next time. Thank you.
Thank you so much.
Mm.